Hello and welcome to the ASPN Young Innovators Journal Club webinar, PNS Guidelines. We will start the webinar in just a couple minutes, give folks a chance to sign in. We'll start in just a minute. Thank you for joining us for the ASPN Young Innovators Journal Club webinar. We'll focus on PNS guidelines. Thank you so much for joining us. I'm going to start things off with our moderator. Please welcome Dr. Harman Chopra.
Hi, good evening, everyone. Thank you for joining us today. This is our inaugural ASPN Young Innovators Journal Club, in which we hope to discuss some of the most groundbreaking papers we've had over the years, including the guidelines that ASPN themselves have published. But not only that, it's more than the guidelines. It's about disseminating the experience these providers have had while practicing these techniques in their field. So we hope that with our journal club, we can really find a new way to discuss these technologies in a way that's meaningful to everyone, clinicians in any area of their practice, whether you're a trainee, fellow, or in practice for years. It's always great to learn and improve your everyday care. So without further ado, I'd like to introduce our introductory speakers, Dr. Roachwalla and Dr. Trewick, who will start things off with the history and background of PNS.
All right, welcome everyone. I'm honored to be here and to be speaking with you. Before we get into the nitty-gritty of things, I'm going to go into some background and history of both electroceuticals and peripheral nerve stimulation. And as trivial as it may seem, I think that for especially those of us early in our career, it's important for us to really appreciate where we started and how far we've come with these therapies in order to really give us hope and motivation going forward to keep pushing the status quo of these therapies. So with that said, I'm going to take you to the very beginning with the ancient Romans, who used to put patients in a pool of black torpedo fish in order to treat painful conditions such as headaches, arthritis, and gout. You even had Michael Faraday, who invented the Faradic electrifier, which, as you can see on the right there, was advertised in the Boston Globe to treat several painful conditions as well as other diseases. Now, in 1965, as many of you may know, Meljack and Wall proposed the gate control theory of pain, which proposes that stimulating those large nerve fibers suppresses pain conducting fibers, which is now the foundation of spinal cord stimulation. And this gate control theory was a few years later verified by Wall and Sweet using transcutaneous electrode stimulation to treat patients with pain. Next slide. Now, going into peripheral nerve stimulation, in 1966, Dr. Sheldon implanted PNS electrodes stimulating at 14,000 hertz to treat chronic painful conditions and give temporary pain relief. However, peripheral nerve stimulation really fell out of favor for decades due to poor outcomes, complications, including nerve damage and fibrosis, and technical issues such as lead migration. In 1999, Weiner and Reed introduced a percutaneous technique to treat occipital neuralgia via electrodes near the greater occipital nerves, which at the time was really a landmark study for PNS. And in 2008, Dr. Huntoon demonstrated ultrasound-guided placement of these electrodes, which really catalyzed peripheral nerve stimulation to what it is now in order to give us more precision and really a feasibility with these percutaneous techniques. Next slide. Now, there are several proposed mechanisms of action for peripheral nerve stimulation, both centrally and peripherally. We touched on the gate control theory, which for the sake of time, I'm not going to go into too much, but there's also central sensitization, which is essentially reducing that excessive peripheral nociceptive activity in the spinal cord, which then decreases activity cortically, especially in the medial lemniscal pathway of the brain. And on the note of central action, you could see on the last point here under peripheral, you're talking about central plasticity. And Dr. Deere actually in 2021 wrote a really good paper talking about central reconditioning or plasticity with peripheral nerve stimulation. And I'm not going to do it enough justice, but essentially using non-nociceptive afferent stimulation to robustly recondition those cortical pain perceiving areas of the brain. And then, of course, we're talking about peripheral mechanisms of action, disruption of the nociception, and on a molecular level, downregulating the neurotransmitters, endorphins, and even local inflammatory mediators. Next slide. This is just a brief overview of the next few slides that I'm going to go over, and really the evidence behind it that was highlighted in the journal. Next slide. So making our way from our head down to the arms. So talking about headaches and specifically migraines, this is the second most prevalent painful condition that we see and causes so much disability within the world. And so it's very difficult to treat, and patients who are refractory to conservative treatments may benefit from peripheral nerve stimulation. One of the most well-studied targets is the greater occipital nerve, and my senior colleagues will go into technical considerations of this, but just looking at the evidence that's out there, there was one randomized control trial that showed almost a 9-day reduction in monthly headaches after 1 year. And as superficially, that may not seem like a lot, but essentially you're giving patients back almost a week of relief in their month, so it's quite significant. Now, with all of the evidence combined, the average effect size of relief for migraines is modest to moderate with level 1 grade B evidence. Next slide. Neuropathic facial pain is such an elusive and difficult condition to treat, and unfortunately, the evidence is limited here to a case series and small prospective studies, but there is promise showing that a majority of patients do get over 50% pain relief. However, like I said, there are no randomized control trials yet, and the evidence here is level 3 grade C. Next slide. So as someone with a PM&R background, I knew that chronic post-stroke shoulder pain was quite prevalent. But funny enough, before looking into this article, I wasn't aware how we could use peripheral nerve stimulation in those patients. And there is actually quite good evidence, especially when looking at targeting the suprascapular and axillary nerves. There were 2 randomized control trials looking at PNS versus conservative management or typical management with physical therapy at both 6 and 12 weeks post-treatment. And the surprising thing is it was not only helpful for pain, but also things like quality of life, shoulder strength, and motor assessment. So the evidence rating here was level 1 grade B. Next slide. Now, there are several neuropathic conditions in the upper extremities. We're talking about mononeuropathies, brachial plexopathies, CRPS, post-traumatic neuropathic pain, and there are several observational studies that do show robust and long-lasting pain relief with both high satisfaction rates and continued device use over long follow-up periods. Now, the evidence here is level 2 grade B after a favorable diagnostic block, which clinically, those of us who use peripheral nerve stimulation, most of us are doing diagnostic blocks. Next slide. One thing that was mentioned in the article was the use of peripheral nerve stimulation for acute postoperative pain of the upper extremity. And there was a current study that I believe is actually complete now, looking at placing peripheral nerve stimulation leads at several nerves for acute postoperative pain relief, but also looking at the reduction of opioid consumption in those patients. So that gives us promise going forward. Next slide. And with that said, I will kick you, Dr. Shaywick.
Thank you, Mustafa. So in this next portion, we're going to go through further PNS indications involving the lower back and trunk. So this is an overview of some of the indications for PNS. Here, peripheral subcutaneous field stimulation, which is a modified PNS approach with sub-Q leads at regions of maximal pain, targeting cutaneous afferents and dermatomal distribution of nerves. We're also going to go into lumbar medial branch nerves, as PNS has been shown to improve pain and function related to mechanical lower back pain, and neuropathic pain related to radiculopathy in particular. So Mustafa touched on the indications of PNS for neuropathy, but we're going to talk about neuropathic pain specifically related to radiculopathies. Next slide. Then we'll go into lower extremity PNS indications. This involves neuropathic pain indications involving specifically the sciatic and tibial nerves, as well as post-amputation pain, for which PNS has been shown to show modest to moderate pain relief. And then we'll also talk a little bit about CRPS type 1 or type 2, and the studies that have shown efficacy of PNS in treatment of these conditions as well. Next slide. So diving a little deeper into the data that supports the use of PNS, we are able to see in the article a review of a multi-center RCT where 33.9% of patients received both sub-Q and optimal medication management and were evaluated at 9 months versus only 1.7% of patients who received optimal medication management alone. And this study was published back in 2019. The article also reviews a study from 2014 that further substantiated PNS's use in this indication as well, with a prospective multi-center study that showed statistical improvement in pain intensity, disability scores, depression, and quality of life measures. And in these studies, we were able to evaluate reduction of use of opioids, NSAIDs, and anticonvulsants in this patient population as well. Next slide. Lumbar medial branch nerves was also discussed in this research paper, specifically axial mechanical low back pain that has been treated with the stimulation of medial branch nerves. The study that they specifically focused on was a high quality prospective cohort study of patients that had previously undergone radiofrequency ablation. And they were able to use PNS in this patient population for up to 60 days and found that 67% of these patients found a greater than 50% improvement in pain intensity, as well as a reduction in disability scores. And then in addition to this, there was a similar prospective cohort study that showed PNS of lumbar medial branch nerves associated with a greater than 50% reduction in pain intensity. This was both at 1 month and 12 months after PNS initiation. And this study was published in 2020. Next slide. And then as far as neuropathic pain, again, Mustafa was able to touch on this a little bit earlier on, but there's limited evidence for the use of PNS in these cases. However, PNS may offer a greater selectivity and accuracy for cases with well-defined neuronal targets. And so this is something that we can keep in the back of our minds as a tool for patients who may have been very difficult to treat for their neuropathic pain that's specifically related to radiculopathies. And this would also involve patients who are post-trauma, patients with phantom limb pain, and patients with CRPS. Next slide. And in talking about CRPS type 1 or type 2 and which patient populations will find greater efficacy with use of PNS, the article really touches on 2 specific studies in particular that we'd like to highlight. One is a retrospective study of 165 CRPS patients. 76% were type 1, 15% were type 2, and we found in this article that there was a VAS pain score decrease from 7.4 to 5.5 at the 12-month mark, and use of opioids were also decreased as well. So very promising for CRPS patients, both type 1 and type 2. And one thing to highlight as well about this study is that they use traditional SCS leads, so not optimized, specifically designed for PNS, and there was a relatively high rate of explantation. So this could be due to lack of efficacy, infection, device discomfort, and other reasons, but it's just important to highlight that a factor could be the SCS leads as well. And then finally, there's also a study from 2020, which was a case series of 14 patients with refractory CRPS of the upper limb. They were trialed with PNS of the brachial plexus, and 10 out of 14 patients were able to undergo permanent implantation and saw significant improvements as well. So this is definitely a promising intervention for both types of CRPS. Next slide. So we'd also like to take this opportunity to introduce two of our esteemed and experienced attendings, Dr. Shustorovich and Dr. Kumar, who are going to go into the next section to discuss a PNS case series, share some of their clinical pearls.
Thanks, Dr. Treywick, for that great introduction with Dr. Brochwala. And yes, we have two great attendings. Dr. Shustorovich from JFK Johnson Rehab Institute, the APD there, trained at Johns Hopkins and then UCSD, and Dr. Ashish J. Kumar, who's been in practice for a number of years now, and he trained at Wayne State. And he's done this procedure greatly in his daily practice. So without further ado, let's get these guys on and we'll dive in with a case series with pointers as we go over Dr. Kumar, really give a perspective from an attendance point of view.
Thank you, Dr. Chopra, for the introduction. So the first case, before we start, the idea here is kind of to do a progression from head to toe, so to speak, of the applications based off of the guidelines that you guys just went over. We thought that would be great to demonstrate some real world outcomes and to kind of triage workup for these folks. So the first case is a cervical spondylosis case. It's an 86-year-old female, had a history of CVA secondary to cerebral amyloid angiopathy. And she actually presented to me with this complaint, referral from one of our general pulmonary doctors for a palpable bulge in the right neck. She was quite thin, so the palpable bulge was actually significant facet arthrosis. If you could see in the x-rays, she has autofusion in some of her joints and vertebral bodies, so quite extensive arthritic changes. It started insidiously without any significant traumatic event. Pain score ranged from 3 to 10 out of 10. Main concern was reduced range of motion, tenderness of palpation, and obviously affecting her quality of life. She had failed conservative treatment, including over-the-counter medications, high-dose Tylenol, and we initially progressed her through the medial branch block and RFA paradigm. Initially favorable, we did the RFA early, next slide please. Early in 2023, and then due to the pain recurring, we repeated the ablation. Actually somewhat early, I was able to get it approved to basically demonstrate that we wanted to optimize the positioning due to her arthritic changes. We did basically a 3-level RFA. However, again, the pain returned pretty quickly, and ultimately she underwent right C4 medial branch PNS placement at the beginning of September of 2023. Next slide, please. So this is a little informatic from Sprint, published by Sprint, just kind of the approach that you may take. The idea here, if you look at the bottom right screen, the fluoro image, typically depending on your target, you would start about 2 vertebral bodies away from your target. So if you're targeting C4, you might start at C6. And the idea is to get the introducer down to your target with about 4 centimeters of purchase within the soft tissue. That's kind of the ideal amount of purchase to make sure that the lead is not pulled out and enough of it is buried into the skin for optimal positioning. Next slide, please. And as you can see here, when you compare the other informatic, you're kind of trying to tend to stand in the lateral border of the facet. And you can kind of see very faintly here the wire towards the posterior elements of the facet joint. Patient initially had 30% reduction of pain at the 1-week follow-up, and then at the 60-day lead pull, she was reporting at least 50% relief, which was very significant for the patient as she was able to do more of her ADLs, improve function, improve range of motion. On subsequent follow-up, I always have patients come back around 6 weeks later to see if they have durability of their stimulation. And unfortunately, symptoms were returning. So at that time, I made a determination to refer her for a permanent placement of a peripheral nerve stimulator, just because our institution does not currently have that available.
And then real quick to interject on regards to the permanent placement, and then along the way, as Alex kind of presents, I'll kind of butt in. But for this patient, the options were to refer to a provider that could do the permanent placement, like I said, for NALU. Just to quickly comment, another option you could probably do too is just consider a repeat, depending on how that patient did, which obviously you're probably talked about. But yeah, next slide.
That's a good point. Actually, since we can have a little bit back and forth here, then when you do the repeats, what is your kind of time frame for repeats with, like, say, if you're using the Sprint system again?
So you have to factor in your Medicare coverage area and certain rules, certain LCDs that can require you to only do it X number of times per year or not. But if you're in a region that doesn't have that kind of line item or statement, then it kind of depends. So, like, I can give you an example. I recently had an 87-year-old male neck pain, very similar to this scenario, or your case actually, and the one on the screen. And he got about 6 months of pain relief with the Sprint Optimus to do a NALU implant, but an 87-year-old male with other comorbidities, the option, basically the decision was to repeat Sprint. So you gotta weigh in the factors of the patient as well.
Yeah, actually, you know, this the case that I just presented, patient did end up getting the permanent stim, and because she was such a good responder, they opted to get bilateral placement. So she hasn't followed up with me, which I assume is a good thing. But from what I hear from the other provider, that she did very well with the bilateral stim for bilateral neck pain.
Nice. That's awesome. All right, next case.
Next slide. So this is now we're progressing down. So this is actually to Dr. Bachawala's points regarding the post-stroke shoulder. So we have two cases that we're going to go over about post-stroke shoulder. This first one is a 71-year-old male with history of CBA and left-sided weakness, cardiac history with CABG, cervical dystonia on Coumadin, and who sustained a left humeral head fracture after a fall, was treated non-operatively, and because of the fracture, he developed capsulitis, adhesive capsulitis, and was referred to me for interventions and management. I started with the left Breisman procedure. If people don't know what a Breisman procedure is, it's basically hydrodistension of the capsule. You're trying to rupture the adhesions within the joint capsule. And then, I'm a DO, so I actually add the Spencer technique, which is a range of motion treatment technique, where you're basically doing manipulation under anesthesia, but the anesthesia is within the joint. It's not, actual sedation. He did fairly well, but the problem is that his pain recurs after about 6 months to a year, and he always gets like this constant 5 to 6 out of 10 pain, limiting his function in the left upper extremity. Other treatment plans, he had tried PT, home exercise program, acute rehab, several injections from even my partner, sports medicine trained as well, and he's been receiving Botox injections for spasticity. So ultimately, we decided he was referred back to me for consideration of suprascap and axillary nerve PNS placement. Next slide, please. This is just an image of his x-ray with the healing subcapital humeral fracture with some arthritis in the joint. Next slide. So we ended up placing the suprascapular lead the first week of July of 2024. Typically, the way kind of coverage works, so with Sprint, at least in our region, and with Medicare Advantage patients, depending on where you're completing the placement. So for me, for example, it's hospital billing or HOPD billing. Has to be done spaced out by a 10-day grace period. And so that means I can't place 2 leads in the same date of service and get reimbursement for that second lead. However, this actually works out very well for our patients because they may not need that second lead after all. And in this case, for example, we placed that suprascapular lead, and maybe because of his body habitus, he was actually getting whole shoulder coverage, which is not exactly expected. Typically, you get 2/3 of the shoulder with that suprascapular lead. Nonetheless, he was very happy. in that regard, so we didn't proceed with the axillary nerve placement, which I was happy about because he's on Coumadin, and so I wasn't really thrilled about putting a wire in the quadrangular space. At 60-day lead pull, he reported about 50% relief. He did not like the stimulation itself, and he was actually not using the device as well as we would have recommended. However, he kind of fell into this delayed response category, because when he followed up later in the year, he was like, actually, that stimulator was great. I had 80% relief, and his only complaint was the tightness and spasticity. So we never progressed him to a permanent because he was pretty happy with his results, and he just continued with our spasticity management specialist for his tone. Next slide, please. So this is the approach. I do mine under ultrasound. I've done a couple under fluoro guided just because we didn't have the ultrasound present that day due to like weird scheduling conflict. But the ultrasound is preferred for me. It's pretty simple, very easy landmarks in my opinion. And the idea here actually for like some clinical pearls would be that you don't actually have to land completely on the os right over the nerve. I've actually found better results by staying a little bit towards the medial portion of the suprascapular notch and actually just popping through the ligament and just so that the ligament can kind of retain the lead a little bit better. It has demonstrated a little bit of, people have just tolerated more the stimulation. You can actually have a better range on the stim. Dr. Kumar, any
Yeah,
on your end?
Next slide, there's a picture, I believe, maybe one more. Okay, maybe not. Sorry, go back. It'll come up as we go through the cases, so we can go back to that original slide. But it was an X-ray fluoro image of a suprascapular lead with 8 contacts. So
yes, that's
yeah, one of the things I guess to quickly mention is positioning is really key. Remember, everything is really tight back here, depending if the body habit is blah, 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 but you have to really plan out how you're going to do it. Sure, you have your shoulder blade to protect your vital organs, but you know, it's planning is key. So I do, if we're targeting the right shoulder, I put the contralateral head turning the other way, putting a bump below that ipsilateral shoulder to kind of get you, depending on if you're doing it with fluoro, better imaging and things.
Okay, and then looks like we have a question that was put into the chat. I figured we'll kind of discuss this as well. It says, when we say 50% of pain relief, what is the best measurement or best combination of measurement systems for pain? Is it subjective or just a visual and/or a visual analog scale or some other combination of measurements? Great question. I would say, you know, visual analog scale is probably a nice little quick and dirty to see how much relief they have. I always ask about function, what they can and cannot do prior to and after the stimulation. You can use perceived amounts of change, right? So that's another type of scale you can use where it goes over specific functional goals that the patient may have had and what the difference is. Obviously, if it's like a neck or low back, you can use NDIs and ODIs.
And then from insurance standpoint, just so he gave you the educational answer, and then I guess the only useful statement would be the insurance answer. And so that's based on the appropriate word would be guidelines. So the guidelines state a 50% improvement in subjective pain relief, but recently they also want a description or a statement about how a patient has improvements in daily activities, improvements in daily function or functional improvements, but they don't quantify, ironically, through what modality you have to do that yet, I assume. So oswestry ODI is I know is a big one that in at least my region, they've been asking along with like just regular auths to show what this question is actually can ask.
That's a good point, Dr. J. Thank you. Next slide, please. This is a schematic for the axillary nerve placement. This is actually kind of the deltoid approach. It can be done by proprioception and by feel. I still prefer the ultrasound just to kind of avoid any kind of vasculature. And I find it gives very similar results to actually stimulating at the quadrangular space. The case that I was going over before, patient was on Coumadin, didn't love the idea that it might be within like a blood vessel bundle. So this was what I was planning to do, and I've done many times in folks and get that additional coverage in the shoulder. Dr. Kumar, what do you think? Do you typically
Do you
use?
do 2 leads? I mean, if you could, would you do 2 leads, like axillary, circumflex, the humeral head, and suprascap? I mean, are you convinced that doing 2 leads really makes a true difference? I know it's a loaded answer because you can't, but I was in the same
Um,
situation.
the next case, I think it would have made a difference, and in hindsight, I wish I did. But the patient was just, as I'll go over, the patient was so happy with the super scap that we
Yeah.
just didn't pursue the axillary placement. But I think the best way to answer that would be, is there motor involvement, and do you want more of a motor stim? And I think that's going to be your determining factor between whether or not you should place that axillary lead. I mean, because stimulating the suprascap with a motor stim, I mean, I don't find as much of a utility maybe you have in your practice.
No,
But
the
stimming,
shoulder, I think it's very spot on. It's easy.
yeah, but stimulating the axillary makes sense because it is, deltoid does help the
Yeah.
rotator.
Awesome. Great.
Cool. Next slide, please. So this is the other patient with post-stroke shoulder, left hemiparesis, very dense left hemiparesis. Doesn't really have functional movement proximally of her left shoulder. Had 2 finger breadths of subluxation and was wearing a hemi sling. She was specifically referred to me for PNS placement because she had tried other modalities of treatment, again, intraarticular steroid injections, Botox. Her main concern was that she had a lot of pain in car rides due to the subluxation. At rest, pain was 0, but any kind of range of motion caused like very significant pain. Next slide, please. So it was the suprascapular nerve lead was placed beginning of September of 2024. This is what it looked like at the 1-week post-op, very clean. Next slide, please. She was reporting 80 to 90% relief, was happy and tolerating range of motion with PT. She was tolerating riding in a car. She was able to get through a full course of physical therapy with the lead. We talked about the axillary lead placement, but she decided to forgo it. And then when we did the lead pull, she was still reporting that 80, 90% relief. However, on the 6-week follow-up that we had just completed at the beginning of this month in the new year, reporting about 50% reduction in pain that was still present, but she was noticing more pain with car rides, a range of motion. And I wonder if the axillary lead placement here with the extensor system would have been helpful for the subluxation. Ultimately referred her out for a permanent. Back to you, Jay.
Yeah, and I think that slide we were looking for is next. Let's see, fingers crossed. Yeah, no, I was wrong, but it's okay.
No,
But concept applies. Well, kind of. Well, this is your image, if you want to talk about it.
Yeah, it was just the image of, so next slide. The image here is just the idea that I want to show that there was actual placement. So you can see that midline lead is definitely in the suprascapular notch. This is an AP view of an X-ray. And then that deltoid lead, you can see him right at the junction between the metaphysis and diaphysis of the humeral head. So right there. And patient had really good stim. Was pretty happy with it.
So one thing that, sorry, that's just quickly came to my head, but so for the perm that you're referring out and they do really well, I know the person that you refer to, if he was on this call, he would talk about it, but basically you got to remember to put that disc to be in a reachable area. And it's ironic, you got to remember that if they're, because they have shoulder pain, chances are they might have shoulder pain on this other arm. So you have to really truly plan out your approach depending on what perm company or whatever device you use. All right, next slide. I wonder when this picture will come. Ah, there it is.
There it is.
All right, so This one was just a perm placement of a 8 contact lead, dropped through the notch. The trajectory of this approach would be determinant on what the other lead would be. And so I kind of connect them and then arrange it depending on where the disc has to go. So for example, if we were to put the disc on the front, I perhaps would have done a lateral to medial trajectory. So that's kind of what I mean by you kind of have to plan out how you want to do it depending on what your nerve targets are.
Now, Dr. Kumar, when you are planning your approach, are you trying to have a distal electrode over the nerve site, or do you try to have it kind of lying as much surface area that's parallel to the nerve? What's your kind of goal?
Yeah. Again, it depends actually on which device you use. But for the one, let's say in this picture, I want to align it. I want the most surface area touching along the nerve, I guess, if that makes sense. So if you're doing a sciatic approach, doing it kind of from proximal to distal so that it runs almost in parallel, if that makes sense. But versus contrary to perhaps the other cases that you're presenting, you want to not be like right on it. You want to be a little proximal because depending on the stimulation type, correct?
Yep, I agree.
Next
All right,
slide.
next slide, please. So this is a younger gentleman and an interesting application of peripheral nerve stimulation. So he's a 32-year-old male, history of some mental health disorders, who had basically first major admission to the hospital due to newly diagnosed IgA vasculitis due to a thoracic spinal subdural hematoma, with cord compression requiring T9 to 12 laminectomy with resection by neurosurgery at the end of 2022. He eventually followed up with me and our spinal cord injury specialist for persistent low back pain, and then obviously for spinal cord injury care. He had been up titrated to this gabapentin to 1,000 milligrams TID, was unhappy with his mental health care provider, was still going to the gym, which I really was respected the hustle there, but the pain was really limiting him, and he had a really poor balance with his legs. So he was often rolling his ankles, lots of ankle sprains, having to use a cane. On physical exam, he had positive facet loading, tenderness to the palpation of the left lumbar paraspinals, positive straight leg raise, tenderness to the PSAS and forward finger. We initially started with optimization of his non-opioid medications. He wasn't on opioids in general, but the idea here is that we were trying our best to optimize the neuropathics, and we were planning for a diagnostic L3 to 5 medial branch block. Next slide, please. This is his MRI. Else fine. He has a significant epidural lipomatosis, lower thoracic post-op changes, and he had an L4-5 disc herniation and L5 disc herniation causing stenosis as well. Next slide, please. His main complaint was axial back pain, though. So we started with the medial branch blocks, and unfortunately, he didn't get significant benefit. Personally, I don't like to ablate young patients. Usually my arbitrary cutoff is 40 years of age. And so even if people do fairly well with the medial branch blocks, I might opt for therapeutic intra-articular steroid injections, because usually it's more of an edematous issue, and anecdotally from my experience, versus a peripheral nerve stimulator, because a lot of the younger folks kind of like the idea of neuromodulation rather than destruction.
How do you choose L3 or L4?
That's a great question. I actually typically split the difference.
That's what I do too.
Yeah, I split the difference. During the procedure, I'll find coverage. If the patient is happy with the coverage that they get, then I'm done with the procedure. If they tell me, hey, I really wish it was lower, I really wish it was higher, I'll move the introducer needle. And the same rule of thumb applies here. So you still want about 4 centimeters of purchase within the skin. Probably want to start at about 2 levels above to get that 4 centimeters of purchase, and I prefer to come cephalad to caudad because of placement of where the EPG is, right? You don't want to have the battery like in their butt, right? Because that's gonna be uncomfortable. How are they gonna hook that up? So I try to get it so it's like on their flank, where it's easily to reach, or maybe it's wrapping with the extensions to like their side. Eventually he ultimately proceeded to the L4 medial branch medial branch PNS in October. He had 90% relief at 1 week. They had tried to increase his amplitudes, but it wasn't well received. He was reporting coincidental headaches. However, he had improved radicular pain as well as improved functioning gait. He was not having as much of an ankle. He wasn't rolling his ankle. He had better dorsiflexion, which was kind of secondary. That wasn't the main outcome. Next slide, please. And this is the schematic of how you would do this. You could do it with ultrasound as well, but I prefer to do it under fluoro guidance just because of the ease, and I have more hands available in my fluoro suite. Next slide, please. Unless Dr. Kumar, you have a, sorry, can you back up?
I prefer fluoro 100%. And then obviously, depending on what your target is, you can do like superior cluneal, middle cluneal. There's a lot of targets depending on the patient. You got to be sure to always tailor it to the patient, and then at all costs make sure you can test, because if you can test, you get immediate reassurance. So it's like instant feedback. It's great.
Nice. Yep, that's awesome. Next, sorry, one slide back.
Go back.
And then, so we had the poll. He hasn't followed up at a 6-week durability follow-up. Hopefully he does well. He may be a candidate for permanent PNS. Typically, you could use something like Nalu or something like Reactivate, but they have technically different functions. And I would defer to Dr. Kumar regarding the Reactivate device.
Yeah. I mean, without getting into the nitty gritty, but they are completely different. Reactivate, it's actually really impressive to see. If somebody hasn't done it, I highly suggest it. It's really impressive. It's cool. Go on YouTube and you can actually see what a muscular contraction is, what it looks like. And what they always say, like, you can't drive with it. And we always wonder, like, well, what about stim and all these things? So anyway, I would highly suggest they go on that YouTube video. It's pretty impressive. But with that being said, they're totally different. And this is truly a multifidus stim compared to a medial branch stim. So at least with my patient population, the ability to have a trial or have a taste is important. And I've just noticed that as a topic of discussion, let's say, for some of the other modalities that are more multifidus based, but every modality is useful. You just got to make sure you tailor to the patient.
I agree. All right, next slide, please. This is going to be our final case. This is for a peripheral nerve in the lower extremity. Interesting case as well. Patient had history of Parkinson's disease, status post bilateral DBS placement with one of our functional neurosurgeons. He was referred to me for a completely unrelated issue. He had chronic left lateral ankle numbness and tingling after a peroneal tendon repair and reconstruction in 2022. He had a positive EMG with cerebral neuropathy on the left. Pain was a constant 8 out of 10. He was wearing a non-AFO brace for stability. Had other medical history that's not too pertinent to this situation. And on physical exam, he had allodynia of the left lateral ankle, posterior to the malleolus along the incision with numbness along the lateral aspect of the left foot. He had tried physical therapy and home exercise program. He's a physical therapist himself, so wasn't going to kind of reinvent the wheel. And he was just taking low dose gabapentin because that's all he could tolerate due to somnolence. Next slide, please. We initially started with a block, and he had about 90% relief for about 3 to 5 days. The decision was made to proceed with the cerebral nerve placement, peripheral nerve placement with Sprint. Next slide. And here you can see, this is kind of a weird picture, but the left leg was the was the leg that was involved. This is him sitting. The head is towards the right of the image, and he had quite meaty legs, so to speak. And so that's actually a posterior. It's going posterior to his actual tibia, but it kind of looks like it's the opposite. At 1 week, he was reporting 30% reduction in pain. Could not sleep with it on, but he had this anecdotal reporting of less supination with ambulation. So from his spasticity from the Parkinson's. During the 60-day treatment, there was a concern for potential lead pull, but we troubleshooted with adjusting his stimulation and making sure his non-AFO brace was not, catching it. Eventually, actually, I think it was by like week 4 or 5. So what this gets into the whole delayed responder slide that we're going to go over at the end of the case. He did start reporting 60 to 70% reduction in pain symptoms, improved gait and function. It was finally reaching kind of like the posterior portion of the 5th digit, although we never fully recovered the full digit coverage that he had kind of at that 4 or 5 week mark. He has an upcoming follow-up with me tomorrow, so we'll see how his durability is. But most likely, if he does not have prolonged benefit, probably refer for a permanent as well. Next slide. And then back to you, Jay.
Yeah, this is a genicular trial. I'm trying to figure out the right image. That one, I'm not really sure. But let's look at the one on the left. So very easy placement for the trial. I do it with fluoro and touch down on os, and Bevel pointed out, and it slides honestly like butter. If you have some osteophytes in the way, that it's not going to be butter. But yeah, very easy placement, very easy to do in any practice setting, clinic or outpatient ASC, HOPD, whatever. Yeah, it's a very dependable, great therapy option depending on the patient's treatment algorithm.
Dr. Kumar, for this knee, you're placing, this was for geniculars, superior medial and superior lateral geniculars, or was this a different target?
In this case, at least, it's superior medial, superior lateral. Another approach you can do is do the femoral branch and the saphenous, the adductor canal saphenous, to cover medial, and then you can do a superior lateral genic. If a patient has more inferior knee pain, you can do a more inferior to superior approach to target the inferior aspect of the knee. Again, it depends on what the patient's pain sources are. You really have to do a history, physical, talk to the patient, map out your trajectory, figure out what your nerve targets are. One thing I did when I first started doing PNS cases was I got that 3D anatomy app, and I literally would learn the trajectory, how the sciatic nerve comes down. It's like meiosis where it splits apart. And then how the common peroneal obviously goes lateral, posterior tibial comes down, and then when you go to the ankle, it even kind of blips out and then goes back down. So like that really helps in terms of trajectory and planning things out, where you're going to put the EPG or the IPG. And then one thing I forgot to mention on the multifidus stim slide, which one do you choose? That obviously comes down to physical exam. There's very delineated physical exam maneuvers and obviously MRI imaging that you're going to look at for the multifidus and the thickness of it if you see atrophy, or is it more medial branch related, depending on the patient's history and what you see on X-ray, and most importantly MRI. But like you said on the next slide, I believe, so this really has always resonated with me, because you hear all the time, whether you're a med student, resident, fellow, and all that, you hear people getting a very amazing trial, and then they get the permanent and they do terrible, and then they get explanted. And it's always like, where did this possibility kind of occur? And this slide really does help resonate, at least with me personally, because it does help explain a little bit, because if you do a 7-day trial, you may miss, like for example, if you look at the week 3, for that there's a little X bifurcation there. So the top line is easy, bottom line is easy, but the middle two, that's where it's like, I wonder, are people getting almost a false positive where they do really, really, really well, and then at around 3-week mark they fall off? And if you think about it, a regular trial for whether it be PNS or SCS, it's 7 days, not prolonged. So it's just food for thought. And the more data we have, the more information we can have to extrapolate.
Yeah, I mean the delayed delayed responder is a really true phenomenon.
Yeah.
And
Especially
I
the
recently,
delayed non-responder. And yeah, or sorry, delayed responder. Yeah, I mean it's like insane. And then I always calm patients down or reassure, like, no, you gotta wait. And then I get worried if they get too well too fast, actually.
yeah, there was a in fellowship, one of our PAs was always like, I always had a red flag when somebody told me they had 100% relief during the trial.
Oh yeah.
Because that is always kind of like, are you sure you had 100% relief? Because that's a really hard thing to achieve. And recently I had it wasn't in peripheral nerve stimulation, but it would apply regarding spinal cord stim. Patient had an outside trial, kind of wavy 50% reduction in pain of 2 days. There was a questionable disconnection of the externalized leads. And then he was referred to me for permanent, because I do the permanents with our functional nerve surgeon. And even the patient was kind of like on the fence. And he was like, oh, but I was told that maybe the rep had said that maybe the permanent would do better. And I looked at him and I'm like, sir, in my experience, I don't think so. Because if that's how your trial went, I'm not convinced that your trial went really well. Usually people don't do as well anecdotally with the perm. Typically it has to do with just finding the appropriate stimulation. Is there a selection bias? Is there a patient just in general placebo that they want? Yeah, secondary gain, they want it to work, things like that. So I always kind of err on the side of caution.
Yeah, and I always tell patients too, like, we really want to make sure this isn't going to be an extra domino on your list, right? This is supposed to improve your function. And I, again, remind them, like, remember that if you fail this, I'm going to be failing with you. And you got to make sure you support them. They feel supported, but you have to protect them. And if they're not doing well, they have to make sure they don't grab for any chance that they can get, because I can't blame them. It's tough to deal with chronic pain. You can't imagine. And it's our job to kind of tell them, though, the reality, the black and white. Like, is it useful, or is this going to help you? Not.
Thank you, Dr. Kumar and Dr. Shastrovich, for a great dive, very comprehensive case series, and loved all the pointers you gave. That these are things that you won't find in the literature. This is you get from everyday practice. And I would like to open the floor up for any questions that people in the audience may have. Feel free to type it in the chat. There are a few moments left we can dedicate to this. Thank you again for listening in for the past hour. We hope you found this event great. I guess one question I had for you guys, with the evolving landscape of how technologies have, as the first presenters mentioned, that PNS has been around for years and then phased out by SCS, now it's back. And now we have modalities in SCS that are changing from paradigm to sort of guided feedback-based therapies. Where do you see PNS going in that realm of where we're adjusting stimulation based on people's everyday lifestyles? Do you feel like that's needed in PNS, or is that central cortical reconditioning phenomenon enough?
You're always there is no such thing as a blanket treatment for everybody. You'll take 10 people and 5 of them may say, heck no, are you not putting anything in my back? I mean, you guys deal with this. We all deal with this every day. And our job is to know which ones. Most importantly, is you don't want to bring a patient's hope up and then let them drop like a sack of bricks because we weren't thorough just to check their insurance and know that, okay, I don't care about what the insurance is, but I care that the patient's hope doesn't go away, right? So it behooves us to make sure that if we're going to be their doctor, you got to check, like, all right, X, Y, and Z insurance doesn't approve this, but you are eligible for X, Y, and Z treatment options, right? So that's another thing I always point out. You really got to factor that in because patients are sometimes they're scared to come, right? And a lot of times you got to give them credit for even taking this first step to come. Apparently, it can be scary to see a spine doctor or an interventional pain doctor. But yeah, I think PNS is great. My best cases have been, like, if I had to pick, were the ones that actually, ironically, had both, like salvage cases. Like they had SCS. There's a large area or some region of their leg that wasn't able to be covered due to, I don't know, prolonged diabetes or whatever. And they just need, and then what happens is your brain will hyper focus on that. And then it kind of puts them back into that chronic pain cycle. But instead, if they're eligible, you can use PNS to target a really region or targeted area to kind of help salvage that almost.
It's a good point. I would just highlight the idea that you're tailoring the therapies to the patient, right? So not everybody is a good candidate. It's something that's why I'm assuming, Dr. Kumar, you're sending your. Actually, I'm not even sure. Do you have to have a psychological eval for peripheral nerve implant?
Mm-hmm.
You do, right?
Well, it depends on what company, but the ones, if one of them, if they require it, they'll let us know that, and then we'll do it. The other one, we do it instantaneously, just like the SCS process, because it's a given, or at least to my understanding. Yeah, and then I do the permanence in the surgery center.
Yeah, Sprint doesn't require it, which is nice.
Unless they ask.
Unless the insurance asks, but it's less likely that they deny because of a psych eval. It's more they just deny because they considered experimental investigational.
Sure.
Fighting. But with any of the other implantables, like true implantables, yes, like DRG, SCS, in my experience, yeah, you do have to hit up the psych eval, which is funny because you can get a nice 4-level spinal fusion, no problems, no questions asked. But here we are. So
a new one, I think, is ODI score is being required, actually. I forgot which company.
For SCS or for
SCS, I believe.
Gotcha.
Another question, with fellowships being as heterogeneous as they are and the exposure they offer to their trainees, what advice can you give to someone, or even young attendings that didn't do this during fellowship and now they have access to do these procedures? Is there a magic number, or is there a way you circumnavigate the lack of exposure? And if so, how do you do it? How do you get your numbers? How do you feel comfortable doing these procedures in some pretty complex locations?
Yeah, I'll tell you how I did it. Dr. Harry Sukumaran was my program director, and he was awesome. Hi, Dr. Sukumaran, in front here. But you only need to see one case. You don't even need to touch the needle. And then if you separately have ultrasound skills, you start with very like class 1 or ASA, whatever, level 1 patients, not hyper obese or anything like that, blood thinners. So, and then over time, you'll get better and better and better. And I think where I started was probably low back with fluoro, because it just depends on what you have access to too. Just because you don't have an ultrasound doesn't mean you can't do it. There's so many. You just gotta think outside the box and not be the same attending that a patient has already seen. Be the young innovator attending that the patient hasn't seen yet.
I would be, that question resonates very well with me. I didn't do any PNS in fellowship just because we had a freeze due to the old lead fractures with the Sprint system, like the old leads. And so they were going through like a whole review process at UCSD. By the time we started doing cases, there was only a few handfuls towards the end of my fellowship. But to your Dr. Kumar's point, if you have ultrasound skills, you know how to identify your targets, you know how to drive a needle. You just need to kind of, maybe play with the apparatus a couple times, and then you can transcribe those skills, placing a PNS lead, and then similar question if you've done, SBS or DRG implants, right? The idea is the same. You make a pocket, you know how to do that sterilely, you know how to open the skin, you know how to close the skin. It's the same idea. It's just a different application of the same fundamental skills you should have learned in fellowship.
Awesome. And we have an audience question in the chat. So do you have any experience with intercostal neuralgia in PNS?
Yeah. You can do it with ultrasound, which is ideal for numerous reasons. Can you do it with fluoro? You can, but I wouldn't go as lateral. But I would use ultrasound, please.
Good reasons. And then one more question. Does the trial have to be performed at an ASC? I did a trial in office and Walker denied, indicating it needs to be done at an ASC.
When you say trial, are you referring to Sprint, or you mean like an actual trial of a potential implantable?
Because Sprint has to be done in a facility. But if it's a trial and then a perm, then you can do that in an office.
Replied PNS trial. Doesn't really clarify. I think they were asking which company, but anyways,
Yeah.
we are running out of time here. Thank you everyone for participating, for creating these wonderful slides. We know everyone has a busy schedule, and this is our inaugural journal club, and we hope to continue doing this. And we're open to feedback. So if you have any, please let us know. My LinkedIn is open. You know how to reach out. And please join us July 17th to 20th, Miami, for ASPN 2025, which is the grand stage for all these conversations to happen. And if you've been to ASPN before, you know how it is. If you haven't, everyone is welcome. So thank you. Have a great night and have a wonderful rest of your week.
Take care. Thank you.